Welcome to the Minor Consult, where I speak with leaders shaping our world in diverse ways. Today, I'm excited to continue our series of episodes that focus on AI and its potential to transform our health. I'm delighted to be joined today by Dr. Karen DeSalvo. Karen is Chief Health Officer at Google, where she leads a team working to create transformative digital healthcare tools. She has decades of experience at the intersection of medicine, public health, and information technology. This includes prior role as National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services and as Commissioner of Health in New Orleans. She served in this role following the devastation of Hurricane Katrina. Karen, welcome to the Minor Consult. It's great to have you here today.
Well, Lloyd, thank you for having me. I'm really looking forward to our conversation.
So, Karen, you came on board as Google's Chief Health Officer in 2019, a few years before accessible large language models like Bard and ChatGPT brought an explosion of interest in generative AI. What was your prediction for the future of AI in health when you began in this role at Google, and how has it changed in the past few years?
It feels like a lifetime ago, to be honest. When I joined Google, the work we were doing here in AI was showing up in two big ways. One of them is we were creating software as a medical device for use in the healthcare environment using what I would now call straight shot AI and looking at how it worked in the workflow, how it compared to a gold standard, what was the area under the curve, taking a long view on getting that model to perform in a way that was going to bring quality but also be safe. We were also using AI, Lloyd, in the background in other ways, though, on our surfaces like search, where we were using a large language model called MUM to help to understand user intent from searches to try to bring them to the right information. But principally, we were thinking about improving healthcare. And doing that mostly for most of the work we were doing was really about how to help the inpatient or the outpatient clinical environment. And I emphasize all that to say, boy, what a difference 5 years has made, because now pretty much everything we're doing is about general purpose AI, which is a completely different opportunity and technology in so many ways, which I hope we'll get into. And Google's journey across that time has been to broaden the way we think about the opportunity for AI beyond what it will do for healthcare, but thinking more broadly about how it can be a helper to not only clinicians, but also to every person, to every consumer along their whole health journey, not just when they're in healthcare.
Google has several existing AI-powered tools, and many of them analyze imaging to detect disease in early stages, from lung and breast cancer detection to diabetic retinopathy and anemia. What are you excited about that's going to come next?
Well, we certainly did start with some of these really important diagnostic areas for people with chronic disease or for cancer prevention. Some of the early work we did was, for example, in the inpatient setting to help diagnose acute kidney injury before it was even detectable to the clinician. That was, for example, some work we had done with the Veterans Administration here in the U.S., but we did some similar work with the National Health Service in the U.K. We also did work, as you mentioned, on improving the detection of abnormalities in mammograms. That was work we did in partnership with Northwestern. We're just finishing some of that and about to publish studies related to AI to improve the diagnosis through ultrasound as an adjunct to mammography. We also did work there asking AI to sort the queue, so to identify for the radiologist what is which films that are in the system are the abnormal ones, so they see those first, sometimes before the woman actually leaves the diagnostic suite, but also when the radiologist is fresher. We did similar work like that with the National Health Service in the UK, understanding not just how well the technology works, but how does it work in the workflow, in the actual radiology room. That technology, we actually partnered with a company called iCAD, and we have externalized it, so they're building that into their hardware systems. Google doesn't make mammography machines, and so we need partners who are going to be able to scale that work externally. Our eye work, very similar. You mentioned our retinal detection work looking at diabetic retinopathy. We call that work ARDA here in the company. And we started it in India and have done work in Thailand. We've got some work in Australia. And those efforts were designed to, again, be able to look at the back of the eye and determine whether or not somebody had diabetic retinopathy and get them sorted to the specialist. And in low resource environments like India or Thailand, it was important to make sure that the highest risk individuals got to that scarce resource for eye care. That work we have actually also spun off. We've been doing work, for example, in Thailand. The government is taking over that technology so they can make it available through their public health systems. We have other partnerships in India where we're doing that work. And I think that theme for the original AI work we were doing holds true across the board. What we learned across this journey, Lloyd, is that we can make the technology. We have great scientists. We can work with academic partners, understand the workflow, sort out what's the best of the best, even start to move it through the regulatory environment. But when it comes to scaling that out in the ecosystem, doing that with partners is the way we have. And you can follow that thread. We have, even recently as this year, we've announced some work we've done with chest x-ray embeddings, where we've created the technology. We've made those APIs available in a place like India that the government can make available to NGOs and others through a website they host. And then we've also done it with a partner called Apollo, who's using that to make it available out in rural areas of India so that they can do some better radiology reading, even if there's not a radiologist in those rural communities. That's the pathway for a lot of our original AI work. And now we're much more oriented towards using general purpose AI and to thinking about how our partnerships are navigated, especially for enterprises, through cloud. It's not the sole way that we work out in the ecosystem, but it is a very important way because, as you know, having a strong data foundation in the cloud is really important to be able to do a lot of this AI work. And it's really important to be able to do that AI work in an isolated environment where the data, the PHI, the personal health information is only available to the partner. We don't want to touch that PHI. So we've really evolved our strategy from using anonymous data to build the model and then handing it off to an external partner. And then we're essentially done once we expose the API or hand off the IP. Intellectual property, but we also now are doing that more with our cloud partners. So we'll expose an API for the technology and kind of talk them through. Here's the art of the possible. Here's what we've built in the research shop. Here's what you could build in your practical environment that will help you do things like nurse handoff, diagnostics, interact with patients that are asking questions in your environment.
What do you think is going to be the biggest impact of general purpose AI, and how do we acknowledge, respect privacy, but also gain the benefit from training these models on increasingly large databases?
So these general purpose models, it's more like having a doctor in the data. And in fact, we've reported out our research on these models and their capabilities in that way. So an example would be the way that we've conducted research and published on a model called AMI, which is a medical intelligence engine that we not only showed that it could get a high pass rate on a medical exam in the US and in India and in other parts of the world, but we actually also tested it with OSCEs, with standardized patients that we test doctors for when we're in training. How well does it do it coming to a diagnosis, and how well does it do that in a way that feels empathetic to the standardized patient? And in those environments, we're able to show that it's as good as or better than a clinician in that controlled environment of a standardized patient. And that, I have to tell you that when I knew that we were doing the work, I thought, well, it'll do well because it knows the literature and it's read the textbooks, and all these patients the standardized patients have read the textbook, so it should go well, and it did. I think what surprised me a great deal was how empathetic it felt to the standardized patients who were blinded to whether it was a human doctor or this AMI bot. And that, I think, opened up, for me, the possibility that these kinds of technologies are not just book smart, but they can help us with some of that art of medicine, not just the science. And that then lends itself to it being more of a, say, a co-doctor with me, co-practicing in the environment. If you think about in your clinical practice, all of us have had those times when you're post-call and you're tired and you're trying to think of things and you're trying to shape a response to a patient or a family's question. And having literally yourself in your own ear as a co-practicing with you in the medical environment is one of the things that I see that we'll be able to develop for clinicians. That time when you've just aced your boards and you're at the top of your practice and you are at your most empathetic self, having a bot that is sort of mimicking you but helping you practice. Not that it's yes, upskilling with the newest literature, but I think of it as sort of bringing your best self to you even when you may not always be there. And then you can begin to extrapolate so many ways that in the clinical environment we'll be able to call on specialists in other areas. So if I need a great ID specialist who understands tropical medicine, it'll be right there for me as a clinician, and I'll be able to, they'll know the literature and they'll know our formularies and they'll know the risks. So sort of bringing all that together as part of my or your medical team is going to be a way that I think it'll just be commonplace, that we'll be using it in every day. I think back to when I was in training and I was using a spiral bound, book, the
Yes.
Washington Manual. You probably
Right.
had one of those that I would flip through and try to get information. Well, imagine that completely digitized and in your ear, helping you just in the moment as you're working with patients. So that we can show that works in the laboratory. We're starting to do some work like that in the field with clinicians around the world to see if it actually in the workflow is helpful. That's one example of how this model it's not just going to read a mammogram. It
Right.
understands the context, the patient, breast cancer, the whole thing. The other lane that I'm really excited about is having that same kind of help and support for every patient in our environment, for every person. Because if you want to help the most people the most, you want to help people in every moment of their every day when they're not in the clinic. And that's the opportunity of supporting prevention, whether people are trying to not develop chronic disease or have chronic disease, automating some of the stuff that gets in the way of us arranging our colonoscopy because it's our chief of staff bot that's going to handle those things for us, to just make prevention easier, to make our own health journey of supporting our own chronic disease management as people a lot more straightforward and simple. And I think we'll reach a place where people will want to have that patient advocate with them. You can imagine if you had a really complicated disease, how great it would be if you had your own personal agent with you in that encounter with the oncologist, listening to the diagnosis, the advice, the recommendations for therapy, looking at your films or your pathology slides with you, because now these models can see and hear and talk. So they are becoming more and more able to contextualize with these multimodal inputs. But I want people to really think about it's not just a helper to the health professionals. It's going to be a helper and an advocate to the people that we're here to serve, to the patients. And that's exciting to me because it really begins to create a way where when my patients would leave the clinical environment like anybody's patient, they forget about half the stuff that we told them. But if that advocate was with them in that clinical encounter by their consent, when it leaves, it's going to say, oh yeah, the doctor wanted you to do this. Or you could say to your bot, can you remind me, can you show me again what they showed me on the EKG? Because I don't remember what they said was the issue. And it will be able to show people.
Wonderful. Well, speaking more generally, most people know Google as a search engine, an email platform, and map application, among many other technologies. Why is Google taking a role in developing AI models for healthcare? I would presume it's a major area of focus because of the broad nature of and utilization of Google search, and because of the impact that health information that's discerned through a Google search can have on the lives of people.
We have a lot of volume of health queries every day around the world, hundreds of millions. We also have a very high volume of health questions on YouTube. And so those are two surfaces where we think a lot about how to see that we're helping people get good quality information. And there are different ways we can do it on those two different platforms. Just say that on search, we think about ways that we want to, what we call, respond to user intent. And the way that we've been doing that most recently is using something called AI overviews, where historically you would, if you asked Google a question about diabetes, you might get a set of blue links. These are the websites. And you might get a knowledge panel, we'd call it, which would show up, think of it like a pamphlet. And that pamphlet might have been created by, say, the CDC. We have partnerships like that to help find quality information. CDC would put it together. We would push that forward. And then we'd have these other links. And what happens in that situation is the person ends up having to do a lot of self-navigation.
Yep.
Stanford site, WebMD site, So AI overviews lets us take those top links and write a set of paragraphs about it that are grounded, we say, so cited. So here's the sourcing of this sentence or this paragraph of information. So if that's the thing of interest to the person, they can navigate and go to that site. People have really responded well to that, and the reason probably is that health questions tend to be complicated. It's
Yes.
People, even if they just type in what is diabetes, they're thinking maybe of type 2 diabetes, or they're thinking more specifically about complications. And the little more you can put together for them, it's more responsive to their interest, and then they can decide, oh, this is the piece I want, I'm going to navigate to it. So we're using generative AI, general purpose AI, to write basically that summary for folks, but setting the temperature in a way that makes it factual and grounded. Might make it a little less exciting, or might be a little boring. That's fine. You don't want a poem about your
No.
diabetes. Usually, you want to know facts, and
Right.
that's what we want. We think about it sort of as a physician. So that's an example of how we've been reinventing in real time the way that we present health information to people. It comes with challenges because there are times, Lloyd, where we don't want to be responsive to someone's question. An example of that would be if somebody's asking questions about how to harm themselves.
Sure.
In that case, we say we want to interrupt user intent and send them to the suicide hotline. So we've already been working in those areas, but we try to weave that in. We're not going to answer it. We want to send you for help. There are ways that we've also been using general purpose AI on YouTube, and I'll just give you one example. We've been working with creators. These are the Stanfords or certified or board certified physicians that make make videos or have channels, and we can say to them, there's a lot of questions coming up about nutrition, and we don't have a lot of great content. Would you want to make some videos? If they do, then we can use one of our general purpose medically tuned models to write a script for them that's grounded. Here's the sourcing of the information. Now you go edit, to see if that saves time for them to create evidence-based high-quality videos. We've just started a pilot program on that. As many of us know, having the first draft of something is often really helpful, especially if you can source the citations. And one of our goals on YouTube is to make sure that we're putting good information out there that people want. So those are two big buckets of examples
Sure.
of where we're already seeing, especially in search, that people love having the AI be able to write a little bit more of a set of paragraphs and respond to information. I think what you're going to see from us is trying to be as helpful to people in their questions as possible in a way that's maybe less generic. And I would think about this. I'm old enough that I gave out pamphlets in my clinics. Sometimes you have a pamphlet for someone that has type 1 diabetes. Sometimes it's for type 2. Sometimes, it's for an older adult or someone who's got cardiovascular disease, right? The ways that we think about and treat that in internal medicine vary. So we're trying to do a better on also trying to narrow that information so it meets the person's kinds of needs and expectations in a way that feels more accessible to them. But Gen AI allows us to do that in lots of ways. And I think over the course of this year and in the future, you're going to see us trying to make it appropriately more personal with respecting all the consent and privacy boundaries. But when people start to ask questions, we want to be able to help them as much as possible.
Karen, for these technologies to work as intended, consumers have to trust the advice and the outcomes. And how are you and your colleagues at Google, who are developing and implementing these AI models in healthcare, how do you think about trust? Because traditionally, and really still even today, trust in healthcare providers and in the access to health information has been pretty high in our society, but we've recently seen some erosion in that. And I think what's on all of our minds is and regain any trust that we've lost through the way that we're implementing AI in healthcare, among other ways.
Look, I think we all believe in the tenet of health moves at the speed of trust.
Yep.
And I know I learned in my practice journey that when I could have a trusting relationship with my patient, they were going to share more with me, and that was going to help me help them
Yep.
more along their health journey. And there's, in my opinion, no way that technology replaces that. On the other hand, it can be really helpful to that. I think that people's expectations of where they want to receive information varies. And I learned that in my time here in a way that I don't think I fully understood even when I was working in public health and trying to message to the population. Yes, it matters that you are culturally and linguistically giving accessible information to individuals, that you're thinking about culturally appropriateness, that it's scientifically grounded, evidence-based. Those are all important principles and tenets, and they're part of the foundation of the way we think about our work. It's also true that sometimes the messenger really matters, and I have to say that even up until the pandemic, going through my time in medicine and public health and government, I still thought of the physician as the authority that most folks would turn to. And what I've learned since being here is that the place most people go first for health information is online. And so before they get to us in the clinical environment or in public health, they're searching on a topic. It could be on the social media platform of their choice. It could be Reddit. There's lots of places people go to start their own learning. And one of the places they go, I mentioned, is YouTube. And a lesson that we learned in the pandemic was how important it was for us to make sure that we were helping influencers. So these are creators that have big followings and have a lot of trust already. It might be a sports figure, it might be a musician. And these individuals are already trusted by people in many areas of their life. And if these individuals are willing to talk about mental health or the importance of self-protection measures in COVID, we can help those creators by providing them, here's the medical consensus or the evidence-based information, here's the ways that people who might be depressed can get help. Right. And they can then carry that message. Sometimes they'll do it alone. Sometimes they want to do it with a clinician. So they might want to, they already have several million followers. They might want to invite into the platform the dean of the Stanford School of Medicine in order to have you talk about, an area of evidence-based information. I think that the thing I'm avoiding saying, but I'll just say it aloud now, is that what we did hear some clinicians say, but we're the authority, let us talk about it, and we had to help them understand that though they are the evidence authority, people are already turning to that sports figure. And so it's that messenger that's willing to carry that is so important, and we have to honor that for people essentially. And it especially during times like COVID, when people were locked down and not able to go to the physician, and there was a lot of discontinuity in care. It was increasingly important that we make sure that good information was getting to people, but through those trusted messengers. I think all to say that. The way we think about trust is there's some grounding principles, evidence-based, medical consensus, that sort of important work. But the messenger also really matters, and that's where we want to make sure that we're being as thoughtful as we can, because we want to help everyone everywhere, not just people who might traditionally turn to a physician for information.
You served as the National Coordinator for Health Information Technology during a pivotal time because it was a time when the U.S. health systems were transitioning from paper-based records to electronic health records. What were the key lessons you learned from that transition, which was a huge transition in the way medical information is obtained, stored, and ultimately utilized?
Well, before I became national coordinator, I had been on the receiving end of it and had been purchasing and implementing electronic health records in our clinical environment, using them in public health. And so I went into that job pretty eyes wide open that there's a lot of change management challenges on the front lines. In fact, in one of our clinic environments, we had already been through 3 transitions by the time I got to Washington. And I think the lessons from then compared to now probably go into a few big buckets. One is that just automating existing processes is a missed opportunity for how the technology can bring joy back to medicine. And in the EHR, we just automated a lot of processes and we actually made them more clunky. And it created obvious frustration, not just for physicians, but for nurses and other members of the team. And as we think about how to implement AI in the ecosystem, though, yes, we can do automation, nurse handoffs, writing the first draft of a note to a patient. These are all really important ways to give some time back, to reduce cognitive load, and bring some joy back to medicine. It's also true that we should be thinking about kind of exciting ways that, for example, I can have information not take 17 years to get from science to the bedside, but that it's in my ear. At the moment it becomes clinically relevant, so I can do the best thing for my patient, no matter how busy I've been. So that's the sort of one thing, is just to think about transformation, not just digitizing a paper process. The second that's really different, though, is with the electronic health record, we were asking doctors and nurses to type in information into a system, and it kind of disappeared into the system in the early days, you might remember. There wasn't anything coming back. There was no return on investment. There wasn't interoperability. The decision support tools were pretty clunky, and we mostly just clicked on the X and closed the box. This technology, general purpose AI, Gen AI, is, as we've hopefully all experienced, dramatically different. It immediately gives you help. And so the return on investment is very exciting. And so the change management is actually, I think we're going to have a slightly different problem with this technology. And that problem is more in automation bias, that we're going to get so comfortable using it, we need to question everything it's telling us. And maybe the third thing that I would say about the differences is that to work with electronic health records and even earlier versions of AI, you needed to be a information specialist, you needed to be a data scientist, you needed to have technical skills. These models that we work with today talk to you. And so as you learn to prompt them to learn how to talk to the models, they perform tasks for you. And the models now are becoming autonomous agents that we will begin to have do not just one step for us, but multiple. Go off and find out this information and come back to me when you have questions, or make sure that this patient of mine is navigating across their cancer care journey in a way that we've prescribed, and come back if you hit a roadblock. And that is what that means, is that every one of us, even if we're not an engineer, will be able to interact with and drive these models, and even build some of the capabilities into the system. And it's creating a flurry of activity, because any small startup / college student / whatever can basically almost create a doctor bot or a nurse bot. And so that comes with a different set of challenges. the easier it is to use these technologies, the more potential there is for there to be downsides, safety issues, equity issues. So it's a lot faster and easier, which means we just have to also all be thoughtful about how we're governing and how we're thinking about using these in the environment, because they're just a lot more readily available than some of the other technology. Can I say one more thing? I have a fourth thing that just occurred to me. The fourth thing
Please.
is,
Yeah.
I think that I think we're going to see that general purpose AI can drive down the cost of care, whereas electronic health records and the
Yes.
systems associated with them are a cost driver.
I agree. I think that's incredibly important. Karen, you've said that AI won't replace doctors, but doctors who use AI will replace those who don't. To what extent could and should AI replace people to advance the healthcare we're able to provide?
I was talking earlier about empathy and how we can teach the models to act empathetically, which is one of our special human traits. But there's much more to medicine than just knowledge and empathy. There's the human connection, there's intuition, there's context, there's so many things that we can't purely digitize. So I still firmly believe that statement, but I do think that we would not be doing our patients a service if we're not using general purpose AI. And I also know that there are many parts of the world, including right here in the US, where people don't have access to health care. They can't just jump in their car and drive down the street.
Right.
They can't
Right.
even jump on a bus. There's nothing. And so the opportunity here is to extend very significantly the care environment. So not just when I'm in the room or at the bedside with the patient, but what can be done across time zones or inter-rural areas. How can we use those technologies to upskill a community health worker in Indonesia on a rural island where they need that doctor with them, that technology doctor to help upskill them in the moment? Those are the kinds of use cases that won't mean that we're replacing doctors, but it will mean that the AI becomes more part of a broader health team. And we should begin to think of it that way, whether it's for safety regulation, but also for performance and the kinds of ways that it's going to extend care to the 8.4 billion people all across the planet in a way that raises quality for everyone.
Well, Karen, thank you so much. I want to end with two questions that I'm asking all my guests in this AI-focused series. First, what do you think are the most important qualities for a leader as we increasingly integrate AI into our professional and personal lives?
There are going to be a lot. I'll tell you what we've been thinking about here. And one of them is about our ability to be adaptable, to innovate quickly. The pace of capabilities of these models is extraordinary, the way that it's evolving. So, I mentioned that the models not only can respond to text, but they can see and hear and talk to us. Companies are working on smell. So they are able to do more in the environment, and even where we build our own models, we have the full stack here at Google. The pace that the capabilities come out is fast, which causes you to have to say, okay, well, it's better if the model can not just read the pixels, but actually be in the clinic environment with the patient and see the screen, see the x-ray with the physician. So what are the ways that we want to just put pencils down on things and move to the next thing? And that is hard for people to do when they've invested time in an effort, but it has much more of a startup mentality than a big tech or even an academic mentality. I think there are implications for the way that we track performance in our employees. I think there are implications in the way that we're tracking KPIs for what success looks like. There's implications for grant making in science, because we're going to start grant making and realize, oh, that technology is already outdated. Let's move to the next thing. So this sort of ability to adapt. I think the other that's really important to us is that we are going as far upstream as we can to have a principled approach to equity and ethics by design. Sometimes, especially when you're working with technology, it's a cool thing. I'm going to build it. One of the big roles of my team is to help the engineering folks think, this is great that you can do it. Will it matter to people? Is there a way that it's going to help raise the floor of health for everybody, and do it in a way that is going to help the most people most?
Last question is, what gives you hope for the future?
Well, I think lots of things have me very excited about living in this era. I think I kind of wish I were just starting my medical career because the hope I have is that, and the thing I think I'm going to miss across not having 3 decades of doing this, is this idea that everybody on the planet is going to have access to the most affordable, high quality care, and it's going to be in their hands. It could be a connection to Stanford in their phone. It could be a connection to a personal LLM that they've chosen to build. But this idea that it's not just for some anymore in some places, but it's going to be for people in a way that's going to really, I think, bring longer, healthier lives to folks. And I was probably 5 years ago when I joined, I didn't see that kind of grand potential.
Sure.
But the opportunity here is pretty great, and I'm feeling extremely hopeful, and I'm excited for this generation of clinicians that they're going to get to live out that journey, and I want to do everything I can to help it come to reality.
Well, that's wonderful, Karen. Thank you for joining me today, for your insightful remarks, and for your leadership in healthcare and AI. Thank you for listening to the Minor Consult with me, Stanford School of Medicine Dean Lloyd Minor. I hope you enjoyed today's discussion with Dr. Karen DeSalvo, Chief Health Officer at Google. Please send your questions by email to the Minor Consult at theminorconsult.com, and check out our website, theminorconsult.com, for updates, episodes, and more. To get the latest episodes of The Minor Consult, subscribe on Apple Podcasts, Spotify, or wherever you listen. And if you enjoyed today's episode, please rate the podcast 5 stars. Your feedback helps make this podcast happen. Thank you so much for joining me today. I look forward to our next episode. Until then, stay safe, stay well, and be kind.